You're listening to
CRST,
the podcast
from Bryn Mawr Communications.
Hello, everyone. Welcome to another episode of CRST, the podcast. My name is Parag Majmadar, and by way of introduction, I am a cornea, cataract, and refractive surgeon, and I practice in Chicago. On today's episode, we'll be focusing on best practices in managing patients with a history of radial keratotomy and those patients who underwent LASIK in the 1990s and early 2000s. On this episode, we have the opportunity to delve into this topic, which is very timely. And joining me are three of my esteemed co-contributors to CRST's April cover focus, Drs. Brett Fisher, Hercules Logothetis, and Marguerite McDonald. I'm excited to hear their insights and strategies for addressing the complex issues that can arise when treating these patients. So without further ado, let's get started. Brett, Hercules, Marguerite, thank you very much for taking time to join me today. Can I ask you all to just give me a brief introduction so that we all know who you are and where you're from?
Yeah, hi. Good evening. I'm Dr. Brett Fisher from Panama City, Florida. I'm a comprehensive ophthalmologist specializing in cataract and refractive surgery.
I'm Marguerite McDonald. I'm a cornea cataract refractive surgeon with Oakley Vision on Long Island. I'm also a clinical professor of ophthalmology at NYU in Manhattan and Tulane in New Orleans.
Good evening. Thanks for having me. I'm Hercules Logothetis. I'm a cataract and refractive surgeon in the north suburbs of Chicago and a solo MD with one OD practice.
Fantastic. Thank you all for taking time to join us today. The interesting thing for at least those of us who are senior ophthalmologists is that we've really had the opportunity to come full circle because we've treated many patients with first-generation refractive technologies like radial keratotomy and LASIK in its infancy. What are some of the things, Brett, let me ask you first, what are some of the challenges that you face when dealing with these patients, and how often do you see these patients coming into your office?
Well, radial keratotomy was a procedure that was widely practiced. About 10% of U.S. ophthalmologists were trained to do it at some point. So there are a large number of post-RK patients out there, and many of them are now entering the cataract age group. So we'll see these patients that, have the typical complaints that any cataract patient would have. But, in addition to that, they can have fluctuating vision. They can have exaggerated, night dysphotopsias. They can have progressive hyperopia. There's a number of unique issues that have been well described that now when we overlay these onto cataracts can be quite disabling.
I 100% agree. And it's interesting, this age group, they're old enough to have cataracts. They had their refractive surgery in their 20s or very early 30s, but they are still sharp. They're with it. They're still very active. And they're, as we'll talk about in a little while, they're very dexterous. They can still insert and remove contacts. Some of them are already wearing contacts to deal with the irregular astigmatism.
So my sort of take on seeing these patients in the past has been that many of these patients were early adopters with first generation technologies, and it would seem that most of these patients are kind of gotten a taste of what it is like to be spectacle independent. And when it's time for them to have technologies like cataract surgery, it would seem obvious that they might be very particular patients. But in this month's episode, Hercules, you brought up an interesting point and mentioned that a lot of these patients might actually be easygoing. Now, that seems a little bit counterintuitive to me. Can you explain your thoughts on that?
Yeah, it does seem counterintuitive, but I think you kind of touched upon it yourself indirectly. A lot of these people, by personality traits alone, kind of were willing to take the plunge, so to speak, back in the 90s and be the first pioneers of patients to have early LASIK and RK. And so I feel like there must be some subconscious component of people that maybe are a little bit open-minded and a little bit more willing to go with the flow. You're correct, of course, in saying that they are used to glasses independence, but especially over the last decade, they've really become accustomed to the fluctuations that we observe with those post-RK eyes. And so I feel like a combination of that early personality trait of being a little bit more of a brave pioneer, plus the changes they've been forced to experience in the last decade, has left a lot of the ones that at least I run into to be pretty easygoing in the sense that when I under promise exceedingly, they seem to be okay with what I'm explaining.
No, that makes a lot of sense. Brett, when you are faced with a patient who has had a history of radial keratotomy or LASIK, and they are now at the cataract stage, what kinds of things are you doing to evaluate that patient in terms of what might be the best intervention for them? And if it is surgical, how do you assess what type of procedure would be best?
Well, I obviously, agree with what both Marguerite and Hercules have said, and I think it is important to assess the patient's desires first and foremost, and are they someone that's very disabled? Are they someone that, you know, is asking for help, that needs help? And I think it really varies, you know, what we're seeing. So if the patients are doing pretty well, I think, as Marguerite will address, there is a role for either scleral lenses or other ocular aids to kind of keep them going. The technology is rapidly evolving in our field, as it has been for many years, and so any patients that are content to wait, I'm content to wait with them. For those that need help now, though, we do have some great options. I have, cautiously done different types of lenses with these patients, from standard monofocals to in a very, stable 4-cut RK with a large optical zone. I've used a multifocal in the past, and in very, carefully selected patients. More recently, EDOF lenses have given us some opportunities to help some of these patients. And now with, pinhole aperture technology in the IC8 lens, we've also got another tool to use in carefully selected patients. So I think it all comes down to, doing a very careful and thorough examination of these patients, doing all the normal kinds of testing that you would do of the cornea to look for irregular astigmatism, to look for potential ectasia issues, and then doing very careful counseling to set expectations appropriately. It may be that the best choice for these patients, if we do surgery, is simply a monofocal lens and then something like glasses or a scleral lens afterwards. So I don't think there's a one-size-fits-all solution for these patients.
Well, I think you bring up a very good point, and I think it's important to point this out that not all patients who had radial keratotomy or LASIK in the early days are going to have significant aberrations. I think some of the sort of knee-jerk, reaction on our parts is that if they had RK, they must have significant irregular astigmatism, but that's not necessarily true. How would you all deal, Marguerite, Hercules? How would you deal with a patient who had either RK or early generation LASIK, but they're seeing relatively well before their cataract has developed? What kinds of options would you recommend? Would you automatically rule out multifocal lenses? Would you encourage them? What's your thought process? And I'll start with you, Marguerite.
Well, as Brett mentioned, there are some well-centered LASIK cases from the 90s, amazingly, and there are some beautifully well-centered 4-cut RKs out there. So if they have good optics, you look at their topography, all the options are open to them, as they would be for anyone else, as long as their ocular surface disease has been treated, etc. It's when you get the decentered ablations and you get the 16 cut RKs with the 2 millimeter optical zone. Those and the fluctuating vision, those are the people who are a challenge. So, as Brett mentioned, the epitheral lens is new. It's just being adopted by surgeons across the country, as is the LAL, the light adjustable lens. And our practice is just embracing both at this very moment. So my thought is, if they have a tremendous amount of fluctuation during the day in their refraction, the IC8 seems like the logical choice there. If they don't have fluctuations, then you might consider the LAL, because you can really, really, really fine tune it. So that's sort of the 10,000-foot view. Certainly, monofocals are still a great choice, especially for anybody with ocular surface disease. The clarity is extraordinary. We don't have a long track record post-approval for some of the other technologies. We will soon.
Hercules, how do you handle a patient who's had RK in the past and is experiencing significant diurnal fluctuation? How would you counsel a patient who's experiencing that?
Yeah, that's a great question. And I can kind of piggyback off what both Brett and Marguerite were saying. I mean, the first thing that I'm always trying to understand in any patient encounter is what is the chief complaint? And then you're really trying to figure out how am I going to solve this particular problem? So um, instead of just kind of repeating what Marguerite said and what Brett said, you have to figure out, is the cataract really the problem here, or is there something else that I can be doing to solve their overall issue? And so let's pretend you've determined that, you know what, this cataract is actually not the primary source of their issue. You then have to kind of answer the question that Parag's asking is, well, what do I do about these fluctuations? I don't personally do CXL myself, but there's obviously cornea specialists like Parag that are around in my area that do. I think it's completely reasonable to think about things that are not cataract options. So you can think about scleral lenses, of course, soft contact lenses, glasses, and monitoring them over time to see if there is any stabilization. And then, of course, considering CXL as an option for stabilization, assuming that you don't think that the cataract is the solution to your problems.
No, that's great. Marguerite, you are certainly certainly have the most experience of anyone probably in the world in refractive surgery, and certainly you've seen your share of patients who've had early generation surgery and now are presenting with various corneal irregularities like Salzmann's nodules, or as you mentioned, decentered ablations and other types of things. What role do you see for scleral lenses in this population of patients?
I think it's an overlooked option. I mean, we're surgeons, we tend to approach the problem surgically, but scleral lenses are so helpful. By the way, the mention of Salzmann's nodules, if they're visually significant, I remove them first, of course, before you do anything else. And that's a pretty straightforward procedure for a cornea person. But I have in the practice close by me an OD who is a spectacular scleral lens fitter. And he does it very quickly, very easily. And as I mentioned before, these people are still usually dexterous enough, young enough, that they can insert the lens, wear it all day, take it out at night without getting help from a partner. And that solves just a host of problems. So if your only option for the person is to put in a monofocal and they still have significant irregular astigmatism, a scleral can help tremendously. You know, there are topography guided ablations, but they're still in development, in my opinion. You know, they're still polishing the diamond there. They're not as popular as we thought they would be by now because they're still being improved and developed. So you can always have that in your hip pocket for the future for the irregular astigmatism, but in the short term, almost every community has at least one good scleral lens fitter.
Yeah, I'll echo that too. And in our practice, we do have an optometrist or several optometrists who fit contact lenses and scleral lenses expertly, I might add. And we find that for patients who do have issues with corneal irregularities, decentered ablations, and even ocular surface disease in this patient population, scleral lenses have been a wonderful addition. In addition to what Hercules mentioned in terms of if they've gotten ectasia, from the RK incisions or ectasia from LASIK, cross-linking plus scleral lenses has really been fantastic in terms of rehabilitating these patients from visually speaking. The problem sometimes occurs when these patients, then need cataract surgery, and it's really, and it's very heartening to see that there are a lot of new options out there. Brett, you mentioned the IC8 lens. What experience have you had with that in patients who have undergone procedures that might have resulted in irregularity, and what's been your experience in terms of how well these patients can adapt to their vision following that lens implantation?
I was one of the U.S. investigators for the IC8 Apthera trial, and in that trial we used it in healthy eyes, and that's a different, obviously, subset of patients where it's now being used, I think, internationally in some of these eyes that have corneal challenges. And, like I think everyone in the US, I'm early in my experience with it. Probably done a dozen or so patients with either post-RK or early LASIK or corneal scars that were inducing some central irregularity. And it's been a mixed bag. I think I'm learning how to better choose which patients will benefit from the technology. I've hit a couple of real out of the park home runs. One in a post RK patient that we implanted it in bilaterally that had just spectacular results, and then a few that have been not as spectacular, but certainly weren't anything that I was worried about. So I think it's really a game of matching these wonderful technologies, as Marguerite mentioned, with the individual patients. And the Apthera lens is very unique in this pinhole aperture. For a patient with fluctuating vision, it's got a very, very large defocus curve. It's very tolerant of a fair amount of astigmatism, up to a diopter and a half. And so if you've got a patient that would benefit from that, I think it's going to really, really make a difference.
Hercules, I think you had some experience with the light adjustable lens during your training. And Marguerite, you mentioned that you are also getting involved in that technology. I'll let you both answer. Hercules first. What's your take on how this lens might fit into this patient population?
I'll definitely answer that for you. I want to echo something that Brett said, just because I'm a little on the younger side in terms of the surgeons here. I think that it should be overly emphasized that every patient in these situations is unique, and there is obviously no universal protocol for all of these, which is why we're talking about all these great options. And so I think it's critical that younger surgeons coming out of residency and fellowship have access to mentors or fellowship options to teach them those things. With regards to the LAL, I was fortunate that my fellowship was a site for both the IC8 and the LAL trials, so I had a lot of experience observing those patients. I think the LAL obviously shines in a situation like post-RKIs in terms of optical aberrations that it is not inducing compared to some of our other premium lenses. And of course, the adjustability component is pretty great. The IC8, I'm glad to kind of hear Brett's thoughts on it, because I haven't had a chance to use it actively in practice now, so I don't have much comments there. But LAL for sure, I think, is the go-to option in a post-RKI in someone who is very motivated and is still trying to maintain glasses independence.
Marguerite, anything to add on your experience with light adjustable lenses, or IC8 for that matter?
Well, actually, we are just installing the LAL equipment, so none of us have done one yet. It's just going into our office, and we're all extremely excited about it. It's wonderful to hear Hercules' experience and to listen to what happened and read the results of what happened in the clinical trial that led to approval. And in our practice, Eric Donefeld, my partner, has put in, when I spoke with him last week, he had put in about 8 of the Thera lenses. He chose extremely significantly aberrated corneas to put them in. And last I talked with him, he was happy. He didn't give me a great deal of detail, and it was a very early experience, but he was happy with his results.
No, that's great to hear. And as I said, it's so exciting to have these technologies. Now, I personally don't have access to the light adjustable lens in my practice yet, and I haven't had the opportunity to put in the IC8. So, what advice would you give, Brett, for someone like me who doesn't have IC8 or LAL? How should we be approaching these patients? Talk about the role of intraoperative aberrometry, IOL calculations. How do you manage those patients, or how did you manage those patients before you had some of these other technologies?
Well, I think that the ASCRS calculator is a wonderful resource. I love the Barrett True K formula for these patients. I think the Haggis is good as well. In looking at intraoperative aberrometry, I am a big fan of intraoperative aberrometry. This tends to be the area where it can be the most difficult to use, especially as the number of cuts increases. So it's it's a great technology when it's used properly. I still want to kind of be belt and suspenders, so I'll have all of my calculations ready beforehand in case what I'm getting from it doesn't make sense. But it can be helpful on the astigmatism side, inarguably. So I think that anybody who has access to monofocal lenses of different types can do a great job with these patients, because there's plenty of help afterwards with either a scleral lens or regular, soft lenses or glasses, depending on, the state of their cornea. So I don't think docs, should be afraid to operate on these patients, because sometimes the right answer is simply a monofocal. And, I don't think you have to have, all the bells and whistles to do a good job. If they have a significant visually disabling cataract, then they're better off having, great, standard monofocal surgery than, probably waiting and suffering visual disability.
Hercules, your same question. How do you approach these patients in terms of IOL formulas, calculations? Do you use intraoperative aberrometry?
Yeah, absolutely. Yeah, I've been pretty lucky. Early. My first 5 years of practice here, so I think I tend to be a little bit more conservative on my selections in general. I treat them like I treat almost all my normal cataract patients. I get biometries for multiple machines, so I have an IOL Master and I have a Pentacam AXL. If I need to, I will repeat both of those. I'll work on ocular surface, of course, and I do recommend to all the post-arc KIs that I also use Aura for aberrometry during the surgery. What I've been lucky with is that I generally rely on the Ascaris calculator. I look at the Barrett formulas and the other formulas that pop up on my biometers. And it seems like every time I've done this, a couple dozen I've done in the last 3 years, the Aura suggestion, my IOL master measurement suggestions, and the Ascaris calculator, they always just line up pretty darn well. And so I've been really successful just with standard monofocal implants in these patients with a little bit of a confidence boost from Aura and the multiple readings. So assuming the cornea is not irregular, I think you can be incredibly successful with very good education and just monofocals, and they do really well.
Marguerite, I'll ask you a question that you answered in the in the CRST April issue, and it's an interesting concept. If you have a patient who's had some type of a progressive hyperopic shift from radial keratotomy, you indicated that you may want to use pharmacologic intervention. So, can you describe your experience with using presbyopia correcting eye drops for this patient population?
I've had a small experience with this, but in the right patient, it can be very helpful. Of course, with the only FDA approved drop at the moment, Vuity, 1.2% pilocarpine. Of course, you have to do a dilated exam, and it's helpful to know, that their refraction is somewhere between -4 and +1, because that's the group that was tested so successfully in the clinical trials that led to approval. So if you know their retina is healthy, and just say, usually it helps to give them a sample, because the bottle is, as we know, about $80, and just explain, try it for 2 weeks. The mild brow ache will go away. The dim sensation of dimness will go away. So unless you have symptoms of a retinal detachment, and I describe those, then just power through it and see what you think. And I've had just a small series of cases where it has helped.
I think this is a fascinating way to use that particular tool. And another way we've been able to incorporate it is there have been international reports in a few patients with bilateral aphthera lenses of some sensation of dimming of vision. And because, almost all of our post-RK patients are bilateral, there is a tendency to want to use the lens in them. And so we're concerned about these reports of dimming of vision. So in order to test this, after the first eye is done on any of these patients, I'm actually putting now Vuity in their second eye preoperatively, after we've done all the things, of course, that Marguerite has rightly pointed out. So we're using this as a trial to constrict the pupil in the second eye to simulate the pinhole aperture effect before we create it permanently. And so far, that seems to be a reasonable surrogate to screen out candidates who might otherwise experience this dimming of vision phenomenon.
Yeah, that's a great point. One of the things that we, I think, are getting better at, but probably need to still pay more attention to is the ocular surface. Hercules, Marguerite, what are your thoughts on ocular surface disease and how it impacts outcomes in this patient population specifically? And also, what steps are you taking to ensure that the optimization of the ocular surface occurs before they have surgery?
I feel like since residency, the importance of ocular surface pre and post operatively has really been hammered home by all my mentors. So I feel like that point for sure is always on my mind with any cataract consult. So I'm always thinking about that. It's not just the post arc KIs, it's really any cataract consult. In our clinic, I'm fortunate that I have a colleague who's an OD who has an interest in ocular surface as well. So between the two of us, we're always kind of scanning for this and utilizing technologies that are available, like MMP9 testing, osmolarity. I happen to have an HD analyzer that I enjoy using quite a bit. Of course, looking on your own for tear breakup time, staining, etc. So these are all things that I'm always looking for with everybody, and I think it's obviously critical in these patients, especially because we all know the measurements are so dependent on the surface, and of course their healing and their outcomes dependent on that. And so I think it's something that everybody at this point hopefully knows, and I assume they know is especially important in these scenarios.
And Marguerite, I know you had a strong interest in ocular surface disease for many years. So tell us your tips and tricks on how you handle these patients.
Well, actually, I'm the director of the Oakley Dry Eye Center of Excellence, and most of my cataract patients come to me through that channel. So my practice has had an unusual profile in that even after I get them all tuned up, many of them are so dry that I couldn't possibly put in a multifocal IOL. So I do more femto, but fewer multifocals than almost anybody in the practice because of the nature of my dry eye population. But we have some of the same instruments that Hercules described. I'm a big believer in tear osmolarity. That guides a lot of my treatment. I've sort of collected my own data over the years. When they hit tear osmolarity of 317 or higher, they get on an immunomodulator. And so I have a whole scheme. And I have found that patients are really grateful if you tell them we're going to diagnose and treat this first, and these drugs work very quickly, we'll have you back in 2 to 4 weeks. Most people are okay with it. They're glad that you've found this problem. And as we like to say, if you diagnose it beforehand, it's the patient's problem. If you diagnose it after their cataract surgery, it's your problem.
That's very true. That's very true. Brett, any other thoughts on ocular surface disease? I'm sure you're a very strong proponent of treating it as well.
Well, I obviously agree with everything that's been said, and I think for doctors that may have more of a representative population, I think the take-home message should be that, if they're so dry that you're having to work so hard to tune them up, you can count on them getting that dry after surgery. And to me, that's been the most important takeaway for me. If I'm just having to really work so hard to get somebody into shape so that they can have a multifocal, I think I'm not doing them any favors, because 6 months or so after surgery, they're probably going to be right back and unhappy with their results. So I think talking to them about what the likely outcome of their dry eye is for the long term is very important.
Yeah, I couldn't agree with all of you any more. My colleague Bill Tratler and I and several of us published a paper a few years ago just looking at patients who walk into your clinic for cataract surgery. What percentage of those patients who never have had a history of dry eye, how much, what percentage of those patients have issues, and what's the prevalence of dry eye? And we found that well over 2/3, probably close to 3/4 of patients had some signs of dry eye, whether it's corneal staining or to decreased tear breakup time. And it really highlights the prevalence of this condition, especially in that population, and how much of an important factor it plays in not only post-operative outcomes, as you mentioned, Brett, but also preoperative calculations and biometry and all of those things. And I think it really behooves all of us who are not only cataract surgeons, but we're all refractive cataract surgeons to really pay attention to the ocular surface. And we're, again, fortunate that we have a lot of options these days to treat those patients. One area that we sometimes hear might cause problems in patients who have had prior RK or prior LASIK is the connection between being able to diagnose them with glaucoma. So, Hercules, what are your thoughts on that connection, if there is one, and what sorts of things are you looking for, and can maybe enlighten our general audience as to what you would be looking out for?
Yeah, I think most people are aware, of course, that once you've had a refractive procedure, RK, that the accuracy of the IOP measurement has changed, and oftentimes it's an underestimate. And I think also, fortunately, the majority of us who see these patients are aware that glaucoma is never as simple as eye pressure. And it's exactly what I tell the patient. Glaucoma is a fancy word for nerve damage, and there's a lot of variables you have to look at over a period of time in order to identify whether they even have it and whether it's progressing. And so for all these patients, RK or not, and you're always looking at the OCT nerve, you're looking at their visual fields, you're checking gonioscopy, you're looking at their pressures, you're looking at the angle. All of these things matter put together to figure out where they're at. So while IOP in these patients, and from my perspective, is essentially a gray area and unreliable, I'm confident that a lot of us have access to a lot of these other data points that can really help you manage these patients appropriately.
Brett, any other comments on that issue?
Obviously agree, and I think that I think that it's going to be more of an issue the longer we go with a lot of these patients. But I think Hercules has summed it up there perfectly.
In the last few minutes that we have remaining, I want each of you to give me your most memorable post RK or post LASIK patient, and what stands out about that case, and what lessons can you share with our audience?
So we talked a lot about pre-op assessments and the lens selection and whatnot, but we haven't really touched upon during surgery what tips, of course, matter in these RKIs.
I'm going to get to that if we have time. Go ahead. Yeah.
Yeah, yeah. So obviously you don't want to run into that RK wound, and we try our best. And unfortunately, I got unlucky a couple months ago, and it was an 8-cut RK, and I thought I was in the right spot in the middle of the wounds. And as I'm going away doing my phaco, all the chamber starts acting funny, and of course, I ended up going into one of the wounds. For a younger surgeon, it's not fun to open up an RK wound in the middle of cataract surgery. It could be a little bit stress inducing. So I just wanted to emphasize that keep in mind, don't ever touch those wounds, and be prepared, especially in 16 cut RKs, that you may need to make a scleral tunnel. Also be mindful of the IOP of the chamber and the stability of the chamber. So I had a case today, I always drop the IOP for my low IOP cataract setting in these cases. But in terms of outcome, this kind of goes back to what I was saying in the article about easygoing patients. So this added maybe 15 minutes to my case. I sutured up the wound, and I was monitoring over the following week because there was a little bit of a dell in there and it took a while to heal, and I had a BCL. But amazingly, this delightful lady the entire time was just so happy with the clarity she had achieved by removal of the cataract alone. She's one of those people that was okay with glasses anyway, but she ended up choosing not even to wear them. So my point is, bad things can happen, and you need to be prepared for them and be mindful of what can happen, but also be encouraged that fortunately in most of these situations, whether it's post-RK or not, I have found that when cataract complications happen, patients generally do quite well over time.
Marguerite, do you have an interesting case you'd like to share?
That was a great one. I haven't had any RK incisions open up on me yet, knock on wood. Just that I agree with Hercules. These people are early adapters, or early adopters, I should say. They are gusto grabbing people. They are easygoing, and I usually end up putting a monofocal in these folks and treating the ocular surface, and they're just so happy and grateful. So happy and grateful. One other thing, you have to be careful with the LASIK flaps. I did have a technician, an OR tech, pass me an instrument, and the patient lurched a little, and it dragged across the cornea and hit the edge of the flap. You got to remember. So there was a tiny, tiny lift at the edge of the flap, which turned out to be okay. But you have to remember that flap is there, and any little thing can rip it up.
Brett, I'll have you have the last word if you have any interesting parting words or parting thoughts.
Well, I'll take the opposite spectrum. The patient that I presented in the print edition, I think summarizes why sometimes it's good to go for it, because that was a woman who'd had bilateral 8 incision RK and then followed by years later bilateral LASIK, and had a lot of irregular astigmatism, and did great with a pinhole aperture lens. And she's someone that was very highly motivated to be spectacle independent, had been waiting for that lens to be released, and probably would have done okay with a monofocal, but did not want to wear a scleral contact lens, and had tried it and just didn't want to do that. So for her, it was a real game and life changer. So sometimes we do need to, venture out of our comfort zone and do things for our patients if that actually is the best option.
Well, thank you all. That brings us to the end of another insightful episode of CRST, the podcast. I'd like to extend my thanks to our incredible guests, Dr. Brett Fisher, Dr. Hercules Logothetis, and Dr. Marguerite McDonald, for joining me here today and sharing these invaluable experiences, tips, tricks, and techniques and strategies for managing these patients who have previously undergone RK or LASIK and are now being seen in all of our practices. And for me, I think the take home is that we shouldn't shy away from these patients. We should offer them as much as we can with new technologies and be courageous in our approach, but also tempered with a little bit of humility, and try to not create more problems for some of these patients who are already dealing with some other issues. So I'd like to thank everyone for tuning into this podcast. If you would like to learn more about the topics discussed on this episode, please check out the April issue of CRST at crstoday.com. Until next time, I'm Parag Majmudar, and this has been CRST, the podcast.
For more shows like the one you just listened to, check out the podcast channel on itube.net.